Welcome back to season 4 of the How We Can Heal podcast. My name is Lisa Danylchuk, and I'm a psychotherapist specializing in trauma treatment. I created this podcast because I'm surrounded by people who have dedicated their lives to navigating healing. There is so much wisdom in each guest this season, and my hope is that this show makes their important ideas and experiences available to you in a way that uplifts and inspires you. These guests and I have committed our lives to fostering health and joy in the world, even as we work through the impacts of trauma and face deep challenges. Let's dive into season 4 and let's keep talking about how we can heal. Welcome back to the How We Can Heal podcast. Today, our guest is Dr. Kathleen Kendall Tackett. Dr. Kathleen Kendall Tackett is a health psychologist specializing in women's health research, including breastfeeding, depression, psychoneuroimmunology, and trauma. She has authored more than 490 articles or chapters and is author or editor of 41 books. Her most recent books include Breastfeeding Doesn't Need to Suck, Women's Mental Health Across the Lifespan with Licia Ruggles, and most recently, Depression in New Mothers, the 4th edition, which is now out in 2 volumes. Dr. Kendall Tackett is an American International Board Certified Lactation Consultant and the CEO of Proclaris Press, a small press specializing in women's health. She also serves as editor-in-chief of the journal Psychological Trauma and was founding editor-in-chief of Clinical Lactation. She's a fellow of the American Psychological Association in Health and Trauma Psychology, past president of the APA Division of Trauma Psychology, and chair of the APA's Publications and Communications Board. She's won many awards for her work, including the 2019 President's Award for Outstanding Contributions to the Field of Trauma Psychology from the American Psychological Association. I first met Kathleen at least a decade ago at an ISSTD conference when she presented on the psychoneuroimmunology of trauma, and I've been a fan of her work ever since. Her recent publications on maternal mental health and breastfeeding have been timed quite well for me personally, and we'll definitely get into some of those topics today. Heads up, some of these conversations get pretty advanced. So if there's terminology that's new to you, you may need to press pause and look up a stress hormone or something that you haven't heard before. I didn't always interrupt to define things because I wanted to get the most out of our time. I'm so grateful to be having this conversation with Dr. Kendall Tackett and to be able to share it with you. So let's welcome Kathleen to the show. First of all, welcome to the show.
Thanks.
Kendall Tackett, your work is amazing. I've followed it for years. I appreciate you so much. From afar, I just want to let you know that. And I've shared your work with so many people who also appreciate it. So thank you.
I appreciate that. Thank you very much. Thanks for telling me.
We were just talking about there's so much we could cover here, and we don't have all the time in the world. But one of the bases of your work, one of the foundations of your work, that I find so compelling and still rare in the awareness of even trauma therapists sometimes is psychoneuroimmunology, right? And sometimes I just say the word psychoneuroimmunology and people go, huh? What?
Yeah, right. Yeah.
Neuro.
That's
a
very long word.
It's a fun word and I love it. And so psychology or, emotional internal experience, neurology, neuroscience, and the immune system, right? We're bringing together these 3. And I think when we put these together, and obviously, I think in trauma right now, we like to really just be like nervous system, like, well, that's not the only system in the body. And that also impacts other systems of the body. So I love that we're starting to I love that psychoneuroimmunology moves in this direction, right? Of including how these systems are interacting, how they're influencing each other. So can you talk a little bit about how you found psychoneuroimmunology and why you think it's important for people to know now or to be aware of?
Well, I kind of first, discovered it, I would say probably 20 years ago, and ended up at it, because I'm also a health psychologist. And so it's kind of like I'd gone to some sessions at APA, American Psych Association, and they had some, speakers talking about that. And I was thinking, gosh, that really makes a lot of sense. So I started kind of reading articles and pulling stuff and thinking, because I was trying to really find what was the connection between childhood abuse and adult health problems?
Yes.
And when I wrote my first article on that, I didn't really include the physiological, which I think to me is a gap. It's something that, I've kind of tried to make up for in other articles, but I did this, I called it 4 pathways. And so I looked at how trauma influences, your behavior, obviously, that's the one everybody points to, but it also influences your cognitions, what you believe about yourself and other people, your social relationships, and also your emotional health. And all of those impact your health. But when we add that 5th piece, which is the physiological reaction, what happens when you're exposed to an extreme stressor, I think that just explains so many problems. And when you look at kind of current research on, all kinds of health problems, cancer, diabetes, heart disease, any of the kind of like autoimmune and, sort of neurological type diseases like MS, everybody is finding inflammation as the underlying cause. And the piece that they forget is the mental health part of that, that actually your mental health can actually kick that off. They're kind of like mutually influential. So it's like your mental health influences your inflammation, but inflammation also influences your mental health. So when you have high inflammation, you're more likely to have depression, but then depression itself increases inflammation. And the thing that I think is so critical to understand is there's lots of things that we observe that are connected to each other. For example, why do people who are depressed actually have higher rates of heart disease? Well, psychoneuroimmunology can actually explain that, because if you're depressed, you have, more inflammatory molecules in your plasma. They actually damage vascular, they cause clots. I mean, they just cause all kinds of mischief. They're in a place where they're not supposed to be, basically. So that increases your rate of depression. If you have kind of a chronically activated, sort of 3-part stress system, you're going to get a lot of abdominal obesity, which is one of the big factors involved in metabolic syndrome. So it's like all these things. The one I think is actually really fascinating is that connection between mental health and preterm birth. We've seen this very, very, very clearly. PTSD, anxiety, and depression all increase the risk of preterm birth, all of them. Okay. And then if you actually understand that inflammation is the culprit here, then you can actually deal with it. Yeah. And people kind of, I say this a lot, and I said this during COVID too. I was just like, they were having all these preterm births during COVID. Yeah. And I'm like, look, okay, here is the answer. You got to get everybody on omega-3s, because actually they've actually found, and this was a nice Cochrane review that came out in 2018. They said that it lowers the risk of preterm birth. Okay. Wow. Why? Because it deals with inflammation.
Yes.
Yeah. And so inflammation is the thing that is the mechanism that is actually connecting that mental health and preterm birth. Wow. And so it's kind of like, and they actually said the evidence was so convincing, no further studies need to be done. Wow. And it's like simple intervention. But again, it's understanding, because people would be like, why do we need to do omega-3s? I don't understand. It's like, because you have to address inflammation. Yeah. And that's one way you can do it.
Yeah. Yeah. It makes me think of yoga too, and mindfulness practices, and, of course, whatever angle on those practices and how they can help. I mean, I even just this morning woke up all grump and then did my yoga and like, I'm fine.
Yeah. Yeah. I mean, exercise has an immediate effect exercise has an immediate effect. And also too, you have the combination of the mindfulness with that, which is just going to shut down that whole, stress system. It's going to make it go in the opposite direction. Yes. I mean, there's all kinds of stuff that do this. And so it's kind of like, but especially I think during pregnancy, that's the one thing I really kind of push is first of all, we have the evidence for omega-3s. We know they're safe during pregnancy. And we also know that they will actually help, so it's kind of like, it's like deal with inflammation. But if we could do all this other stuff too, it's great.
Well, I'm an N of 1, but I took omega-3s every day of my pregnancy, and I went to 42 weeks. So
there you go.
Really want to have them hanging in there.
Yeah. I mean, and that's actually one of the things they found when they did this big supplementation study. They said that a lot of the women ended up being post-dates.
Yeah, so pregnant. You're like, all right, that's enough.
But especially these high-risk groups. I mean, it's really critical when you start thinking that preterm birth is actually the number 1 cause of infant mortality worldwide. Yes. Yeah. So this is a big deal. And, especially when you talk about health disparities and stuff, I mean, it's kind of like the preterm birth is kind of where a lot of that is, because that the same groups that actually have high infant mortality, a lot of them actually also have preterm babies. So it's kind of like, if we can keep that baby in for even just a couple of weeks, it makes a difference.
And so the assumption there then is that that is because of inflammation, or the studies support that that is
Well,
because of the
okay.
inflammation.
Guess what those inflammation molecules do. Okay. So the three big ones we always talk about with depression: IL-1 beta, IL-6, and TNF alpha.
Yeah.
Guess what ripens the cervix?
All three of those.
And especially IL-6 and
Okay.
TNF alpha. They ripen the cervix. So it's kind of like it's
Okay.
telling your body, hey, it's time to have this baby.
Yeah.
Plus, I think CRH, which is part of the HPA axis stress hormones, actually also speeds up the placenta clock. So it's
Okay.
kind of like, yeah. So you got that's the mechanism right there.
Yeah. Wow.
Yeah. But it's kind of like, oh my gosh, when people don't understand this, it's like, this is critical stuff.
Yeah.
And there's lots of ways to turn that inflammation off. But I think especially in trauma, that's actually really important, because what happens is when you've had traumatic events, especially if you're talking about adult trauma, someplace new, child trauma kind of seems to work in a little different way in terms of adult health. But, if you've had, like, say, combat experience, it seems, or sexual assault, something that's happened to you, or partner violence, which also way ups the rate of depression, not surprisingly. But it's like your stress system becomes very sort of hypervigilant, and it becomes very kind of, and so it doesn't take much to set it off. And so then you're kind of like having this chronic elevation of all these stress hormones. And that's one of the things that causes a lot of the health problems.
Yeah.
So it's kind of like we got to recognize that what we're trying to do is dial that down. That's where exercise becomes very helpful. It's a very empowering thing that people can do that will actually help them turn off that stress system. That's what we're trying to do.
Yeah.
Yeah.
And this, we know, the short-term responses of trauma, right? Our body is adaptive. It's trying to heal.
Exactly.
It's trying to fight. It's trying to flee. It's trying to freeze. It's trying to stay alive.
It's trying to recognize things that are similar and that are frightening. And so the body is doing what it's supposed to do.
Yeah.
But we kind of have to understand that, instead of, saying, oh, what the heck is doing? And my body's being crazy. It's like, no, your body's trying to protect you.
Yes.
Yeah.
So what do you see that keeps those stress responses on, right? So it could be unresolved trauma, it could be culture, it could be a number of things, but we're looking at, like, well, what keeps them on, and what are the bridges to bring it down? It sounds like exercise. I mentioned yoga. You mentioned omega-3s. Like, there's all these bridges that we can take to, I would say, it's not always soothe, but to support our system into finding.
We just know so much about, like, all kinds of interventions, like, for example, postpartum depression.
Yeah.
Okay. And almost all of them, when you look at the evidence, you can actually see that in some way they actually address the stress system. Antidepressants turn out to be anti-inflammatory. Now, they're not strongly anti-inflammatory. That's why they work better sometimes if you add an omega-3 to them. We find out that cognitive therapy, because I think your cognitions are one of the things that really drive. Because remember, you're looking for, friend or foe. Okay. So if you have experienced trauma, your worldview is going to probably be something along the lines of, people are out to hurt me. Okay. And that is a worldview, the pessimistic worldview, that actually is specifically related to increased inflammation, and they can tie it specifically to disease. And it's something a lot of times that trauma survivors don't even think about, and nobody addresses it with them. But I think that it's actually as harmful to health as smoking.
Yeah.
But I think one way, this is where I think some of the behaviors come in, because when you look at kind of the behaviors that you see that are common trauma survivors, okay, substance use, self-harm, high-risk sexuality, a lot of times bulimia, eating, especially bulimia, you see a lot of times that people do it. It's like the tension rises, and then they do something that releases it, which obviously is not actually helpful, in the long run. It's not a good way to cope, but it is the way to cope. It's like a way that people have managed to kind of sort of self-medicate, and kind of, try to bring those symptoms down. So kind of, I think what the challenge is to say, okay, here's some other ways to do that won't be as harmful. But I think actually, if you go around through the world, having this said to people are kind of going to harm you. I mean, which isn't unrealistic if you've experienced trauma.
Right.
Because you've experienced that, but it's kind of like partly learning, not to necessarily just throw off all kind of, distrust, but to kind of like be a little more discerning and also recognize that's not true for everybody.
Yeah.
And that's not going to be true. And so I think that that's one of the things that I think can be helpful is like that's where I think cognitive therapy is very helpful. But like interpersonal psychotherapy, you're increasing your social support. That is specifically anti-inflammatory.
Yeah.
So just all these things. And that's why, like, so for example, when I talk about like emotional health impacting health, physical health, you see that, people who are depressed or have PTSD or have anxiety tend to also have chronic health problems.
Yeah.
And it's kind of like, okay, so can we address some of these things? So maybe some of these health problems can improve.
Yeah.
I think we want to make sure we do it in a way that doesn't blame people for their problems.
Right.
But to just say, this is the way kind of we've tried to cope, but, let's kind of try something that actually I think you find is going to work better.
Yeah.
Yeah.
And that's what I love about your work and about psychoneuroimmunology is that we start to understand trauma responses in general. Mm-hmm. We then understand that they're adaptive. Oh, this was trying to keep me safe. Right. We then understand it's trying to keep me safe. But now that I'm in these other environments that maybe actually are a little bit healthier, the thoughts, the imprints are actually harming me. Right. So working through that, healing through a relationship with a therapist, through other things, through getting support, through, testing some of those boundaries, which can be scary.
And having a positive relationship with a partner.
Yes.
That's super healing. But you also see a high percentage of people who gravitate toward pretty unhealthy situations.
Yes.
So, it's kind of like, how can we sort of navigate that so they're in partnerships that are going to contribute to their health?
Yes. So there's some amount of leap of faith of this is possible out there. Right. And then there's probably going to be some stumbling around and finding things that aren't the healthiest, but knowing that the healthy thing is possible and knowing that there's, I kind of hear these two, like the worse it gets spiral. And then the better it gets spiral. Because once you get, if you have trauma and then you're in an abusive relationship, it's like, well, this is just more harmful. And then that's impacting your thoughts in an even more negative way. And not feeling self-worth. And this is a spiral in a certain direction or this accumulation of trauma. Whereas once we can bridge out, let's just say it's omega-3s or it's individual therapy or it's a really cute cat like you've got over your shoulder right now.
Okay, you need to get down.
On video. Oh, it's fine. We welcome all the felines.
That's Liam.
Hi, Liam. For those of you on video, you got the little treat. So like if we can bridge into a place of comfort, of connection, of our body, our being getting the support that it needs, getting in this, you mentioned you specialize in health psychology, being in that healthy state. Right. Well, from there, it's a lot easier for me if I'm cuddling on the couch with my dog or cat for my partner to come home and be like, hey, babe, how are you doing? Instead of like, why didn't you load the dishwasher? You know what I mean? Like it just changes our state. And then the more, it's almost like I hear as you're describing this, like the harder it gets, the better it gets. So I always think about like, well, what are these bridges in between?
Right.
And what helps us to recognize, okay, I'm in this place.
Right.
There's a reason, there's a good reason. I understand I can have compassion for it. But how do I travel into the psychoneuroimmunological state that is, I get to be human and I get to connect with people.
Yeah.
So I'm wondering.
And I think that's one of the challenges, because I think part of it is kind of like learning to evaluate, okay, this situation is actually pretty toxic. I think I need to put a boundary here or get out.
Yeah.
And it's kind of like, I think that there's a process that takes, because, this is one study that, as you were talking, I was thinking about. There's a researcher named Terry Messman-Moore, and she's done a lot of stuff looking at re-victimization. Okay. Why is it that somebody who, say, experienced childhood sexual abuse ends up, maybe being sexually assaulted again, especially in college? And the rates of that are really shockingly high. Yeah. But she kind of, she's looked at substance use as one possible. And again, I think that is something that's a way people sometimes cope with past trauma, and that puts them in sometimes dangerous situations.
Mm-hmm.
and I personally know some friends who that was exactly their experience.
Yeah.
They went off to get high with somebody they didn't know and they ended up being sexually assaulted again. I mean, so
Yeah.
unfortunately that does happen. It's like you're trying to kind of, use substances to deal with previous trauma. And then, yeah. So, but what she looked at that, but she also looked at something else, which I thought was really interesting. This study really just stuck with me. She was doing kind of a simulated, like a kind of a video game, and she had it with college students. And again, very high rates of re-victimization in college samples. And what she found is you were supposed to go through this kind of like situation, and you were supposed to identify when you thought it was dangerous. And she found out that the women who had history of sexual abuse got farther into the situation before they said this is dangerous.
Interesting.
And I just thought that was the most interesting study, because I think that's exactly what happens.
Yeah.
I think in some ways you kind of learn to tolerate things that you probably shouldn't. And then I think
normal.
I think that's one of the kind of paths to kind of like discover, is like to say, no, this isn't okay. I'm not okay with this.
Yeah. And to have be a complete sentence and to be able to divert. It's just making me think of, we had Deb Dana talking about polyvagal theory this season, and we were talking about neuroception, right, from the polyvagal lens. And I told a little story about being in Italy and, meeting some people out and then being like, oh, let's go to this club down this dark alley. And I was like, no, bye. I don't care about anything right now. I'm going the other direction. And, perhaps having had a different history, being like, oh, it's just, I don't want to rock the boat or whatever it is.
Right.
To work with survivors of sexual assault and people who are actually actively still being trafficked in Oakland. And we would go to the grocery store together and someone would just start talking to them. And my whole body system was on alarm, like, no, go, get out of here. Do not talk to this person. And they would approach them. They would talk to them. And I was like, we have different levels of comfort and safety. And let's talk about that. Let's talk about how, you wanted to engage with this person and I felt very unsafe and why I think that might be.
Right. And kind of like, does this sound fishy to you? And does this sound dangerous to you? And it's kind of like, I have a friend who actually was catfished out of a lot of money.
Okay.
And it's kind of like there were red flags, but she kind of didn't see them.
Yeah.
She was kind of in a situation that wasn't great, with family and stuff. And so this person kind of was reaching out and offering stuff, but it was kind of like, now she's kind of like, somebody says something like, well, lend me money and then I will send you a check. She's immediately like, no, and she got on the phone with the police because now she kind of knows. But, it's the same kind of thing, kind of like ignoring the things that you think are, are like, oh, I don't want to, and I've done this myself, I don't want to be judgmental. It's like, no. Now I've actually learned, listen.
Listen, you can listen and still be kind or just be clear.
Kind. Yeah. Right? And just say, no, I'm not okay with that.
Yeah. Yeah. And that whole just like no being a complete sentence.
Yeah.
So there's so much in your work I want to talk about. So just to wrap the larger discussion of psychoneuroimmunology, I want to touch upon, because I've seen so many people who have a severe trauma history and also are dealing with health issues and have a hard time getting support with that.
Yep.
I'm thinking of things like chronic fatigue, fibromyalgia, even things you mentioned, IBS, things that oftentimes they're having a hard time getting support from the medical institution because maybe they'll get a label eventually. Oh, it's fibromyalgia or it's chronic fatigue, but there's often not a clear treatment plan with that. No. So are there any points of hope that from this understanding of our experiences influence our mind and bodies, these impacts and responses to trauma are very physical. The challenges and negative things you're feeling are also rooted or related in physicality.
Absolutely.
And then there's that bridge where I'm thinking, oh, it'd be great if you find a doctor who's like, we've got this, we understand that, and we're going to help. Let's get you on this regimen. But what hope or guidance might you offer someone who's in that place of, I know this feels connected to me intuitively. I'm not getting validation externally, but I want to heal and I want to move forward. What wisdom or guidance or direction would you send those folks?
Well, first of all, that's a very hard place to be.
Mhm.
Okay. That's,
Mhm.
you know, especially some of these, you know, chronic pain syndromes, you know, what they call the functional pain syndromes, they're hard because, you know, there's lots of people who don't even think they're real. You know, I will say this about that. You know, they've actually looked at things like sleep studies, like let's take fibromyalgia, for example.
Mhm.
Okay. Because, you know, the problem is nothing shows up on a normal lab report.
Yeah.
Right. So then people kind of say, that's not even really real. Okay. This is why I think it is. This is why I think it is. Because when you look at something like a sleep study, okay, that's not patient report, that's sleep. And what they find is like there was a couple nice papers about this in the American College of Rheumatology journal. And what they found was that, you know, like you normally, like a normal sleep cycle, let's talk about that for a minute. You know, it's like you start off and you have, you know, at the beginning of the night, you have longer stretches of, you know, the deeper sleep, the slow wave sleep. And then you kind of, you know, you cycle up and you go to the more active state, which is REM. And you're kind of going back and forth between, you know, with these, you know, with stage 1, stage 2 in the middle, and then 3, 4, which is the deeper sleep. Okay. So normal people who aren't ill, actually, you know, they tend to have these long stretches of REM at the beginning of the night, and then they got a little bit of REM and long stretches of slow wave sleep, and then up again to REM, and then it switches about halfway through the night, and that's when you start getting the longer stretches of REM. And REM sleep is interesting because you're almost awake.
Yeah.
But you can't move because you're actually paralyzed during REM sleep. So they call it paradoxical sleep, but your brain almost looks like it's awake.
Yeah.
You know, but it's during slow wave sleep that your body heals from all the little micro traumas and stuff that happen during the day. You smack into a table or you stretch a muscle, something like that. If you don't get slow wave sleep, you have pain in every part of your body. And what they found in the sleep studies is that what was happening is this alpha wave was intruding over the slow wave sleep.
Yeah.
And so basically, functionally, what they were happening was they were getting no slow wave sleep.
Oh.
Okay. And that actually happens in depression too, because what happens is they call it a reduced REM latency, which is, you know, big clunky way of saying you're cutting off the first part of the night. And so REM, you're reducing the amount of time before REM becomes the predominant state. And so same thing, you're not getting that slow wave sleep. And so what they've done, like in the lab, is they brought in healthy volunteers and they put them, you know, hooked them all up. And as soon as they started hitting slow wave sleep, they started waking them up. Wake them up, wake them up, wake them up every time, you know. And I always joke, you know, like who would sign up for that study?
Yeah.
That's not like that. But what they did is they induced fibromyalgia.
Wow.
You know, and so it went away in a couple of days, you know, but it's like pain in every part of their body. So part of it is kind of understanding what's going on. So then you start kind of putting a real, you know, emphasis on, okay, sleep is really important. Okay. What can you do to improve your sleep? And it might be, you know, you do some of the cognitive behavioral therapy. It might need a combination of medication, you know, but you have to kind of know that. But the other thing that they found with fibromyalgia, and this is again to say, when people come back and say it's not real, when they've looked at cerebral spinal fluid, 3 times the level of a peptide called substance P, which is high in pain. Okay. So your body, there are physical markers. They're just not in the places people normally say. So don't let people say it's not real. It is absolutely real. But what they've kind of found, especially, you know, with there were a lot of studies on irritable bowel and trauma, but basically what they found is these, you know, these flood of stress hormones, especially if they happen during childhood, but actually you can have it happen during adulthood too. You know, something significant happens, you know, a childhood abuse, but it could be a car accident. It could be that you go through a really nasty, awful divorce. I mean, that sometimes can trigger this big flood of it. What it seems to do is lower the pain threshold so that normal sensations are experienced as painful.
Wow.
So I think that that's when you would do something like, okay, let's do some mindfulness and kind of recognize, okay, this, you know, I'm experiencing pain right now, but this is, I'm going to see if I can kind of calm this all down. You know, doing the things that we know that are going to actually calm down that stress system, finding an exercise that is comfortable and can do it. And there's a book I always recommend for the chronic pain syndromes, which I think is fantastic. It's called Managing Pain Before It Manages You. Yeah, no, that book is just amazing because like what it does is it talks about, okay, you know, how do you do certain things like during the day, and then you add prophylactic rest.
Yes.
And then, you know, also to keep in a pain journal, kind of like, okay, when is pain the worst? So you get the idea that there are times where there's things going on that seem to trigger the pain, and kind of like you're seeing too, also too, it's not all the time.
Yeah.
And so it kind of gives you a little bit more control over it.
Yeah.
And so there's lots and lots of great strategies in there. And part of it's the cognitions, because one of the things that really can happen is, you start kind of like working yourself up. Oh my gosh, this is going to be like this until I die. Is this just going to get worse and worse? So you can really make it kind of worse.
Yeah.
But it's tough. It's tough. But that Managing Pain Before It Manages You, really, really good book. And it's just, and they've even got some suggestions like, how can you do some like task, like, say around your home or your office or something like that, in a way that doesn't, really impact you physically and doesn't, really hurt you. So kind of like, okay, are there some small things you could do together? And so it's very empowering because it kind of like helps you sort of ramp up. Because that's the thing, if you feel horrible and you can't work, you can't do stuff around your house, it really kind of helps you kind of get over that hump, and it kind of shows you what you can do and what you can't do, and kind of what are the realistic sort of boundaries.
That's amazing, because it helps go from that place where you can start to feel really paralyzed, right? Well, if I can't work and I can't do things around my house, I'm just sitting here in pain, and gives you again some bridges out right here.
Right. Because, medication obviously is helpful, and that definitely is part of the plan, but it can't be all of the plan.
Yeah.
Because I have lupus. So it's kind of like, I've been through a lot of this myself. Yeah. And I went 7 years before I was diagnosed. And so also totally understand this, but it was kind of like, one of the things I learned is, okay, like here's normal, and medication maybe takes you to here. Mm-hmm. And that's when you start trying a lot of the alternative stuff.
Okay.
Yeah. To help, so chiropractic and physical therapy and acupuncture. And I do all of that. So
yeah.
Yeah.
Yeah, bringing in
yoga
resources. And yoga in a way that works for you, right? Because I think sometimes people, especially if they are experiencing a lot of pain in their body, and I've even experienced this, like, breastfeeding and sitting all day and my back hurting.
Right.
Like, I can't just get up and do a vinyasa. Like, that's not where my body is. So finding, okay, I'm going to start on the floor, and I'm going to do this thing that feels like relief, and I'm going to do this thing that feels a little bit challenging, and I'm not going to do the things that feel impossible or painful. And even in terms of classes at studios, you can talk to teachers and just let them know and find ways to make it work.
Yeah, because I've actually showed up for some yoga classes and actually really hurt myself. So it's kind of like, I am careful about, and I've got hypermobile joints. So it's kind of like, they're fragile. And so I kind of have to, kind of be careful. And I've had a lot of injuries because of them. And so it's like, so it's kind of finding a level, and I think sometimes it's tempting to kind of want to jump up and say, well, this is super easy. I don't know, I can do some more, and it's like, next thing you know, you're in trouble. So you kind of learn those boundaries. But I would say the biggest thing to the patients who have, IBS and fibromyalgia and chronic fatigue, and it's like, there are things you can do within it. Yes, there are limits, but life is not over. You can do some things that will actually improve the quality of your life. Absolutely. And part of it is just understanding this, especially if there's a trauma history related, but this hyperactive stress system. And it's kind of like, okay, let's, we got to be thinking about, okay, what are the ways we can bring this down? We can bring this down with social support, you know? Yeah, we can bring this down, we can bring this down with medications, obviously, but we can also bring it down with, some of the other things that we've talked about, cognitive therapy, mindfulness, all very, very helpful. So
I want to shift. I think this is a great bridge. I want to shift into there's the impact of trauma, and you and I both have seen a fair amount of that, and how it can have a really painful and negative impact on our bodies and our systems. And then there's the impact of connection. There's the impact of play and joy, and there's the role of oxytocin. So I have a number of questions and comments along these lines, but I'm even thinking for folks that are having that, like, a lot of pain, just a simple exercise of like, what might bring you joy today?
Right.
And maybe it's smelling a certain flower or calling a certain friend. And, these things that can seemingly be small can actually be related to relieving pain.
Yeah,
and
definitely.
I think understanding that and mapping that. And again, this is why I appreciate your work and so many of the people you're citing. It's like to really map it and see, oh, we can see this on an fMRI. Oh, we can see, hormones or stress responses changing.
Yep.
And experiences changing over time. So powerful. So let's talk a little bit about oxytocin. Okay. And selfishly, I just gave birth last year, and I've been breastfeeding.
So you had big doses of oxytocin going on.
Doses. Oh, so good. It's the best. I read your book, Breastfeeding Doesn't Have to Suck. Great title. 2022. I
My
believe.
editor came up with that.
So good. And I read it in, I think, early 2023 before she was,
Good.
and I just read it cover to cover and bookmarked a bunch of videos and stuff that you reference in there. And then it really helped me and supported my breastfeeding journey. And so let's talk a little bit about oxytocin. What do we know about the role of oxytocin for people in general and for, breastfeeding moms?
Okay. So I think part of the thing to understand is, okay, we've talked about that sort of 3-part stress response. It starts with what we call the catecholamines. That's the fight or flight that triggers the sympathetic nervous system. Okay. So that's what most people think of as the stress response. But then that also then kicks off something called the HPA axis, which is this 3-part response. But this is where you get the stress hormone cortisol. And then we also have the activation of the inflammatory response system. As we said, that especially that inflammation piece is really the underlying physiology to so many physical health problems, but also mental health problems. It is the thing that is the physiology underneath all of those conditions. So the trick is, okay, how do we turn that off? Well, there is a mechanism for that, and it's oxytocin.
Yep.
Because those two things, the stress system and the oxytocin system, are both controlled in a little portion of the hypothalamus called the paraventricular nucleus. And basically that decides which one of those is going to be on. And they're mutually suppressive. So if one becomes the one that's upregulated, it suppresses the other one. So if you have oxytocin is upregulated, it is going to suppress stress. Yeah. But the opposite can happen. Stress can suppress oxytocin. And you see this in birth. Birth is a great example of this, because this is when a woman has the most oxytocin in her life, is when she's in labor. Yeah. Okay. And so what's happening is you're getting this, these pulses of oxytocin. Every time the baby's head hits the cervix, it releases oxytocin, and it doesn't make it necessarily easy, but it makes labor so you can tolerate it. Yeah. It kind of like helps kind of prepare your body, and so when things are going well and oxytocin is flowing, labor progresses normally. And it's not easy. Okay. But it makes it so it's tolerable. But what happens if you do something like stress a mother during labor? You can stop it right in its tracks. And that happens all the time. That happens all the time, because the hospital can be a really frightening place, unfortunately. And that's still true, and so something happens, and you get in there and maybe the providers aren't very nice, or it's physically cold, which happens a lot in hospital settings, or, there's people in there that you don't know. And that's just activating like what we call the lizard brain, the part of your brain that's really looking out for, things that are dangerous. And you can stop labor, and then they come on and they say, well, let's bring on some synthetic oxytocin. They pump that into mom. And what that does is make labor a lot more painful. So guess what? It stops the natural oxytocin. It's because you've hit it, you've turned it to the stress side. Okay. And so you've activated that, and that will, and a lot of times you bring PIT on board, or Pitocin, which is synthetic oxytocin, and you end up with a cesarean. Yeah. It just stops things. It stops things. And so that you got to think about that kind of basically they're two sides of the same coin. So if oxytocin is up, it actually really is very, it's healing, it's health producing. It makes you trust people. It makes you want to be around people. It makes you connect, it makes you feel good. And there's so many ways that you can actually release oxytocin. Obviously birth and breastfeeding are like the two biggest ways, but sex, particularly, enjoyable sex, if it's actually comfortable and the people that care about each other, that really makes a difference. They found group singing releases oxytocin. Yes. I think it's really cool. Petting a dog. Yes. Because you have receptors in your hands. You can release oxytocin. Having a baby skin to skin. You can actually, have that, because you have a lot of oxytocin receptors on the skin areas of your chest. That's a really kind of sensitive area. It's a really kind of vulnerable area. So it's kind of like, when people kind of intrude in that can actually be very stressful. Yeah. So there's lots and lots of ways you can actually kind of increase that oxytocin. And this is actually one of the ways I talk about how, exclusive breastfeeding actually protects mother's mental health, because it actually acts as a down regulation of that stress system. Yes. And it's really, really clear. Now, if women are partially breastfeeding, they don't necessarily get the same effect. They get some of it, but this seems to be, unfortunately, I wish this weren't actually true, but it is. We've seen it just in study after study. There's this kind of threshold that exclusive breastfeeding seems to be different, and it really specifically turns it off. Now, what's kind of interesting is this is actually a paper I'm right in the middle of writing, but there's different neurons that are involved. Okay, so like we compared when we were writing skin to skin versus the baby actually at the breast.
Yeah.
And a study that's like now 23 years old from Germany actually did see that there was a big difference in terms of looking at the HPA axis, so cortisol, and they looked at ACTH, which is another stress hormone from there. But they found that it was like these mothers, when they tried to stress them in the lab after they had the baby at the breast, that they couldn't, because there was this like little cloud around them for like half an hour. Now think about if you're doing that day after day after day, multiple times a day, what that's going to do. And it seems to have a permanent effect, because when you look at these women, like in, when they're the average age of 63, as one study did, 139,000 mothers or women. And what they found is that those women were at lower rates for cardiovascular disease, hypertension, high cholesterol. I mean, it was just amazing, because again, what you're doing is you're having this constant down regulation of the stress systems. So what happens is at suckling, you have actually this extra activation. So with skin to skin, it releases oxytocin up to the paraventricular nucleus. So you do get that stress reduction, but that's with these kind of smaller neurons called paracellular neurons. Okay. But then with suckling at the breast, you get those plus this big, think about walkie-talkie versus broadband internet in terms of like information, that they're transmitting. It sends up to this nuclei over here, and also, another one called the SON, or the super optic nuclei. Okay. So basically you're going to two parts of the hypothalamus with a big bolus of oxytocin. So it is qualitatively very different than just having the baby at skin to skin. And so it's like, that's why it is protective. And it's like, whoa, that's what's doing it. That's what's doing it. And so then you start kind of applying it to like, okay, so for example, like in our data, we actually saw that mothers who had planned C-sections had higher rates of depression.
Interesting.
And I was puzzled by that. It was even higher than the women who had emergency C-sections. And I was kind of like, what is this? And I was talking to somebody who did oxytocin research, and she goes, yeah, that makes perfect sense, because if you don't have the trial of labor, you don't have that big bunch of oxytocin on board.
Yes.
She said, if you at least have the trial of labor and then you have a C-section, you at least have that.
Yeah.
But what they were finding is when they would put babies skin to skin, the mothers were having less of an oxytocin response to that because they didn't already have that. So what they did actually is they gave them synthetic oxytocin to kind of bump it. Okay. And that seemed to help actually. But, it's like we think, oh, yeah, just having a planned C-section is just exactly the same. It isn't. Now, there are medically times to do all of this stuff, but it's like we have to recognize that there are going to be some disadvantages, and then let's take steps to counter those.
If you're listening to this podcast thinking, I want to learn more body-based tools to help support trauma recovery, then you might be the perfect candidate for the Yoga for Trauma online training program. This 8-week certification is for wellness providers and enthusiasts who want to learn the theory and best practices for providing yoga and somatic tools to those navigating the impacts of trauma. Students often come into the Yoga for Trauma online training program, or Y4T as it's come to be known, knowing at a deep level that mindful movement can help with trauma recovery, but not knowing precisely how to articulate it or share these tools with others. Y4T breaks it all down and leaves you feeling clear about your choices as you support folks navigating post-traumatic stress. Of course, the experience is good for you too. With 8 modules and 8 yoga classes, you'll get a taste of how it feels to practice yoga in a trauma-responsive manner. Head on over to howwecanheal.com/Y4T to apply and join the program today. Mention the podcast in your application for a special bonus. One more time, nice and slow. The website is howwecanheal.com/Y, the number 4 and the letter T. Looking forward to seeing you there. I want to ask about something we just talked about in terms of quality of life for general people, trauma survivors, in terms of psychoneuroimmunology, sleep.
Oh, yeah.
Because with new parents, sleep is such a thing. I mean, you meet a parent you've never met before. How old's the baby? 3 months. How are you sleeping? Right.
Yeah.
That's what people ask. And so
it always is.
What in your mind what does healthy sleep look like for early parents?
Okay. So the first kind of qualification to point out is that all new parents are tired.
Mm-hmm.
Because people say, well, I breastfed and I was tired. It's kind of like, it's really not a question of tired. It's kind of a question of more tired.
Yeah.
And this is actually where I think the sleep research is really interesting. Now, I did several of these studies, but there were other people like Helen Ball in the UK and Jim McKenna. They were anthropologists. They've done a lot of interesting work on mother-baby sleep and sleep patterns. And what's really kind of crazy, and this is the thing that I think a lot of times surprises people, is I was sure that exclusively breastfeeding mothers got less sleep. In fact, I wrote it in an article.
Yeah.
I actually said, I'm not sure how they're getting less depression because they're getting less sleep. So I can't take it back. It's out there. It's like, it's an article that's been used quite a bit. But what's interesting is I discovered that's actually not true. They're actually getting more sleep. And it doesn't seem like it's possible because they're waking up more, they're waking up on average, sometimes 2 or 3 times more. The baby's sleeping, a shorter amount, at the longest stretch. From the baby's perspective, that's actually more helpful. That's actually, keeps them alive, because that's one of the theories of SIDS, is that babies get into such a deep sleep, they can't rouse from it.
Wow.
Okay. So yeah, that's actually, so from the baby's perspective, that's good, but that's like not very helpful to tell an exhausted new mother, really. But what's interesting is, like as soon as you start adding supplementation, the mothers get poorer sleep. And it's just really strange. And I think part of it is, how long does it take you to get back to sleep? I think that's really the kind of the key issue.
Yeah.
Because if you think about it, if you're formula feeding, you actually have to get up out of bed, turn on a light, go to the kitchen, and by this time baby's kind of hysterical. So it takes a few minutes to settle everybody down.
Yeah.
And that wakes you up. And so it takes you longer to get to sleep versus you got the baby right next to you and you just kind of slide your arm over, and it's like, I'm not necessarily even saying you have to co-sleep, but if you have the baby near you where you can get to the baby easily, you can go ahead and feed the baby and you can get back to sleep.
Yeah.
And so it's easier. You don't even have to turn on a light most of the time.
Yeah.
So, and the advice they were giving parents to go out and sit on a couch, very dangerous.
Yeah. Because you can fall asleep there.
Very dangerous. And you want to talk about bumping up your risk for SIDS,
Right.
It's like, yeah. So, Peter Blair is a big sleep researcher in the UK. He actually said, look, ever since we've been giving people this ridiculous advice, your SIDS rates are going up.
Yeah.
These babies are dying, don't do this. And so, yeah, and our study showed that too, that a lot of, I think we found 25% of parents were admitting to the fact that they were doing that and falling asleep with their babies on the couch. But okay, so this is what I would say. Okay, so what if you've got a mother who's just like absolutely hanging by her last thread? Okay, because I think that this is important. We do have to pay attention to, are they tired or are they in that more tired range? They're tired where they think they're going to die if they don't get some sleep.
Yeah.
Okay. And so to just tell somebody, oh, keep going. Yeah. Just, I think can be really quite unkind.
Yeah.
So I have kind of a strategy for that situation, because I think it's important that we acknowledge that too, and I because people will say, oh yeah, just don't breastfeed at night. First of all, very unworkable. And it will probably, if you want to keep breastfeeding, it's probably going to tank it.
Yeah.
Because it's going to tank your supply. I mean, so, and you're going to end up, you go 6 hours, which is what they recommend, you're going to get mastitis.
Yeah.
They're just not thinking about practicalities like that.
Yeah.
But what one researcher called Goyle found is that 4 hours of uninterrupted sleep is really important. That the people who didn't get that were more likely to be depressed.
Okay.
And so let's work on that. Okay. You got a mother who's kind of hanging by a thread. I'm thinking this is kind of a temporary kind of part-time strategy.
Yeah. So
let's have her, because what you're going to need is an awake partner to take care of the baby, because otherwise you're going to wake up. You're going to, you hear that baby, you're going to wake up first. Okay. So you need somebody who is awake to take care of the baby, because then you can actually downregulate enough to go to sleep. Okay. Sleep for that 4 hours and then have the baby near you for the rest of the night. And I think you're going to find that really turns things around.
Yeah.
So what I recommend from just a practicality said, have the mom go to bed at 8 o'clock, do the 8 to midnight. And then that way, if their partner needs to go to work the next day, it's still doable.
Yeah.
Yeah. And they're not going to be like, because we got to kind of pay attention to that, and I've had mothers, I've been there myself, where it's just like, you feel like if I can't get some sleep, I will die.
Yeah.
And so we do have to pay attention to that. But generally speaking, if a mom has a baby near her and she's exclusively breastfeeding, she's getting more sleep.
Yeah.
And in all the other things that are markers of kind of physical well-being, they're less depressed. They rate their physical health as better. They say they have more energy. I mean, but that's relative.
Yeah.
They're saying 3 on a 5-point scale, so they're still not super peppy. But the other groups, as soon as you supplement, the number is lower.
Yeah.
And so, yeah, that's pretty much the sleep research is really unanimous on this. And again, surprised me, absolutely surprised me. But, every study we've seen come out has said the same thing.
Yeah.
Yeah.
And then the sleep is going to impact, like we talked about before, experiences of sleep are going to impact feelings of just well-being, mental health in general.
Absolutely. Absolutely.
What have you found in
everything.
terms of social support for mothers in particular who are breastfeeding? My personal experience, my friends are so great. They're all just like, how are you? How are you? How are you? After early postpartum, first 6 months, everyone's like, are you good? Are you good?
Yeah.
And I was good. But I felt like the hardest times I had were not, there's moments where you don't get enough sleep for sure. Right. Were when I didn't feel like I had social support. Like I would ask someone, can you help? And they couldn't, they're at work, whatever.
Right.
Or like, those were the hardest mental and emotional moments for me. And so I just found that really fascinating, and it fits in with everything we know about how social connection impacts our bodies. But I don't feel like we talk about that a lot in terms of, I'm not seeing posts on social media about, hey, make sure you're like supporting other mothers. Or I feel like culturally we're kind of strained in this area. So what have you found research wise and solution wise for social support for mothers?
Well, it's funny because social support I always found very interesting, because it's like the way that they always talked about social support. I remember finding myself thinking, but is that actually support? Because they would say, oh, she has all these people around.
Yeah.
Are they being helpful?
Yeah.
Are they being critical? Or is she feeling like they're being critical?
Right.
And it's like, I didn't feel like people kind of made that distinction. Yeah. And it's kind of like a lot of the current research now, they actually have this scale called the perceived social support scale. And guess what? That's better at predicting postpartum depression versus this quote classical social support scale.
Yes.
Which I think is actually really interesting. And it kind of goes with what I thought, and I always kind of go back to, there was this, show, it was like one of the BBC shows that they show like on Masterpiece Theater, but it was called, I think, The Bishop's Wife. And this woman had been away. She had depression and she'd ended up being hospitalized for it. She was a vicar's wife. And she, the ladies of the parish came and cleaned her house before she came home. And she said to one of her friends, she said, I have never felt more violated in my life.
Wow.
And I thought, well, because it's like, unless you kind of invite that.
Yeah.
And so it's like, I think people were trying to help, but it turned out to not actually be help. And I think that's the way a lot of things that, are called support are. I think sometimes like so-called support groups are not very helpful, because mothers get into these weird competitions that in the end mean nothing. Yeah. It doesn't matter whose baby slept first. It doesn't, none of this matters. Yeah. It's having now 2 adult children, I can tell you all that stuff that people cared about, it doesn't matter. And so it's like, when you've got a situation like that, that's not helpful. But you can have relationships with other mothers that can be extremely helpful. Yeah. So it's kind of like to know, and again, this kind of comes back to that discerning what is kind of helpful for me and what is not, and to like give mothers permission to say, this isn't supportive to me.
Yes.
But I think you probably saw in that in the Breastfeeding Doesn't Need to Suck book, I talked about a couple of studies. They just come out when I was writing that. And there's this one in particular I think is really good. It's looking at partner support for breastfeeding.
Yes.
And so they talked about the different kinds, like informational support or, sort of kind of like more kind of the material type support. But they said the thing that was the most important was actually what they called responsive support, where they talked to the mother about her feelings and her goals and kind of what she wanted to do. And there was empathy there, like kind of like, okay, this is, what you kind of want to do. And this is where we want to head, and just really supporting her, having nothing to do with the breastfeeding. And they said, if that part wasn't there, the duration rates and exclusivity rates actually went down. when that other type of support was there, because what the mother experienced is criticism and coercion.
Yeah.
And I thought that's really interesting because, you know, when you take like the IBCLC exam for the lactation consultants, you know, they always have these questions like, okay, you got this situation, what would you do first? And the right answer is always, you know, support the mother. So
Yeah.
they were right about that. That actually is kind of the most important thing. And it's like and again, it comes back to that perception of support, you know, so sometimes just asking the question, what do you need? What can I do to help you? You know, what are your goals here? You know, I see this with abuse survivors. A lot of times people try to make decisions for them.
Yeah.
You're a sexual assault survivor. Oh, you don't need to worry with this. This is going to be hard for you. And it's kind of like, but it could be a very important goal.
Yes.
You know, in our study of 6,410 mothers, we had a group of almost 1,000 mothers who indicated that they had been sexually assaulted. Okay, so the most serious, you know, this included the group that had the most serious type of child sexual abuse plus teen or adult. Okay, so really serious trauma.
Yeah.
And what we found is they exclusively breastfed at almost exactly the same rate. Actually, the sexual assault survivors were just a touch higher, but it was like 78% with both groups. You know, and so it's kind of like, I think sometimes people make decisions for abuse survivors or trauma survivors that aren't appropriate. And that to me is, I call that the dark side of trauma-informed care.
Yeah.
You know, it's like,
it happens in trauma-informed yoga too. Oh, don't teach this posture. It'll be too triggering. It's like, well, do you know that? And can you offer bridges and options for them to choose it if they want it?
Right.
Not make it the default. You're not going to force, hey, everybody, we're starting in this pose. Everybody start here. But
kind of say, hey, this, you know, could be triggering, you know, you can try it if you want, or, you know, it's kind of like, but yeah, that's the thing. A lot of times you find out that, you know, the mothers are never consulted about what their goals are. And it's like, that is very undermining. That's not support.
Very disempowering.
Very disempowering.
So let's talk about supporting mothers who are particularly experiencing depression. That's what your volume 1 and volume 2 books that are coming. Are they available yet to the public?
Yes, they are. They are available. They're actually both on Amazon. This is actually the causes and consequences of depression in new moms, and this is on assessment and treatment.
Yes.
So they're both on Amazon. They're both available from Routledge. That's the publisher. But so sorry, I got busy showing off.
So excited about the books. I love it. And are those, so let's just talk about, you know, I'm sure you get into so much depth in the books, but how can mental health providers and society at large better support new mothers to prevent and relieve postpartum depression?
You know, I think actually probably one of the most helpful preventative approaches is kind of like outlined in this book that my publishing company published called The Gentle Art of Newborn Family Care. She was a postpartum doula in Santa Cruz, California, before there was even such a title. But the way that she just goes in there and cares and loves on these families at a time when they're just vulnerable, you know, even something like making sure there's some cut up food that a mom can eat one-handed. You know, this is kind of in that immediate postpartum time, making sure that the laundry is done and that she has clean sheets, you know, and I would say probably clean clothes. I think putting on some clean clothes every day, I think is really important for your mental health. Yeah. You know, and what's interesting, you know, it's like, we had some papers that we published, you know, we published a lot of trauma paper or COVID papers during trauma, you know, during that time and in my trauma journal that I edited. And one of them was really interesting. It was about how one of the things that was very harmful during the lockdown for people is they lost a sense of time.
Yes.
You know, that time just ran into each other. Weekends and weekdays, night and day were indistinguishable. They were isolated from other people, you know, kind of, they felt like the world was sort of going on, you know, and they were kind of out there. Does that sound familiar?
Yeah.
It sounds like being home with a new baby to me.
What day is it? What time is it? I don't know. You know, all I know is I'm feeding this baby.
Yeah. So I would say probably the most important things that people can do, especially kind of in those early weeks, is take care of the other stuff so that she can just sit and focus on the baby. And also kind of affirm her, because she might feel like, I'm not doing anything. It's like, your body is very wise. You know, it's telling you it's time to rest because you just made a human being.
Yeah.
Now, not everybody can do that. You made a human being. That's incredible. You made a whole other organ just to support that human being. So you're not doing, you're doing nothing. Seriously.
Yeah.
So part of it is kind of just affirming that, and kind of affirming sometimes those things that if she feels like the world is going on without her, it's kind of like, how can we break that isolation for her? How can we make sure that there's clean clothes that she can put on every day? That's just a really important kind of thing to do.
Yeah.
Can you hold the baby for a few minutes so she can go grab a shower?
Yes.
Wash her hair. She's going to feel like $1 million after she does that.
Mm-hmm.
So there's just a lot of those kind of personal care, because everybody kind of comes in and thinks, oh yeah, I'll just take care of the baby. And it's like that, for the most part, isn't what she needs, except for maybe having those quick breaks to go, and run and take a shower or something.
Yeah.
Or maybe somebody, she feeds the baby and then she gives, to the baby to a trusted person so she can take a nap.
Yeah.
But who will come and get her when the baby needs to feed again.
And the trusted person is so important, because like you said earlier, the mom's not going to rest.
Right.
If they're not feeling that their baby is safe, or
Yeah.
just whisking in and taking the baby away is not the solution. That could put mom in a stress response, right? It's what's supportive, what is soothing, what is actually responding to what the mom is expressing that she needs.
Well, and again, like I said, if, we need to remember that the things that are helpful, and this kind of covers all three of the things that I do, if you want to help prevent child abuse, if you want to help prevent depression, and if you want to encourage breastfeeding, because, particularly in higher risk populations, it really is related to some very important markers of infant mortality. Okay. So, I mean, these are kind of big things to do. We don't necessarily find that to be as true in affluent communities, but particularly, for some of the lower income, communities, we find actually, this is serious stuff we're playing with, but the same things actually do all three of those. And it's not swooping in and grabbing the baby. It's, tidying up her house, going and get some groceries, maybe going with her to, say, to go see the lactation consultant and writing down the answers. Sometimes moms get very anxious. Okay, like, I don't think I'm making enough milk. That's, I've had moms who are making enough milk to feed the entire neighborhood worry about that. I mean, seriously, I was sitting down, at 3 weeks. I had this one mom, the baby was having trouble latching, but she had a really abundant supply. I mean, it was just pouring into the baby and he was like thriving.
Yeah.
But she could sit down with one of those crappy little battery operated pumps and fill up a 4-ounce bottle. Shoop. And then she put it on the other side and she'd fill up a 4-ounce. And she goes, I don't think I have enough milk. I was like, yeah, you have enough. You're doing well there. Keep it up. Nice. It's amazing, actually. But, it's like, okay, so the partner could be very useful to say, okay, what are the signs that the baby's not getting enough to eat, and being alert for those and kind of knowing, and that allows them so they're partners in this enterprise, and for some moms, it might be like their mother, or it could be a friend who's coming in, if they're single moms, they don't have a partner, it's having a trusted person there, that could fill this role. I think that actually helps mothers get past that very vulnerable first few weeks, and, so then they start kind of, by about 6 weeks, things kind of change and babies go through kind of a big brain shift, and it starts getting a little bit easier. It's never easy, but it does get easier. And the mothers start feeling like they're not complete, newbies, and they've actually learned a lot and they figured out a lot. And, by that time. And so, but those first few weeks, especially, I think are absolutely critical. But even as you go on, mothers can actually get depressed later.
Yeah.
And especially like if you've had, say, for example, a baby in the NICU. Yeah. What is a really common pattern that I've seen is that the moms all of a sudden, say, like at 9 months postpartum, suddenly crash.
Wow.
Baby gets out of danger, doing okay. And then it's okay for mom to just kind of say, so there's going to be lots of different times, where she needs that kind of social support, but to just sort of like love on her, find out what she wants to do, and really do those practical things. That's really the most important thing you can do. Yeah. Yeah.
And I just wish our society were a little more structured for that. I mean, I think the amount of time people get off work and
right
like that.
It's insane. Yeah. They say that 25% of mothers in our culture are going back to work at 2 weeks. That's just obscene. Yeah. It's obscene. It's obscene.
And you compare that to other countries where people get years.
Right.
Literally.
Right. at least having a few months. And, I'm not sure we've got a great answer to this yet.
Yeah.
But it's like, it is, I think it's one of the trickier policy issues that we have, because it's like, what's the situation like if you have an employer pay for maternity leave, but the mom decides to stay home? That can be kind of a tricky, so I mean, it doesn't suggest an automatic solution, I guess, is what I'm saying. Yeah. And so it's like there's, you do have to address the issues of cost, but I think honestly, 3 months at a minimum, I think is what everybody deserves.
Yeah. Absolutely.
But unfortunately, it doesn't happen. And, so then it's kind of like, I think that's when the support becomes really more important. Otherwise, you keep having repeats of these really awful cycles.
Yeah.
Yeah. So impoverished situation, and it kind of leads to another, generation and another generation. I mean, so it's kind of like, let's break that cycle. And there is a lot of wonderful grassroots work that's being done in the African-American communities, where the community has come together and are doing things like having, doulas and home birth midwives. And I mean, so it's so heartening to actually see that kind of work in action. I think it's fantastic. I'm really cheered by it. It makes me feel like maybe things can be better.
Yes.
Yeah.
Well, that's a positive note to wrap on. My brain is swimming with so many things. I feel like I could do an entire season of just interviewing you, or an entire podcast where we just talk every week. And I just like pick at you have so much knowledge and experience, and it's so well integrated. And I literally have a million more questions. So if you want to come back on the podcast.
You know what? Honestly, anytime. It's been really fun. I've enjoyed it. Yeah. And you cover you cover trauma, you cover postpartum. I mean, it's like, it's like.
I want to do a whole season that's all about maternal mental health, but I just couldn't not ask you about that today. And so this is like a little preview, and then maybe we can talk a little bit more about that more specifically. But yeah, I feel like we could just for hours and hours. Again, thank you for your work, for your time today, for everything you're doing to support mental health and well-being. Thanks so much for listening. My hope is that you walk away from these episodes feeling supported and like you have a place to come to find the hope and inspiration you need to take your next small step forward. For more information and resources, please visit howwecanheal.com. There, you'll find tons of helpful resources and the show notes for each show. Thanks for your messages, feedback, and ideas about the podcast. I love hearing from you, and I so appreciate your support. There are lots of ways you can support the show, and I'm grateful for every little bit of love you share. If you love the show, please leave us a review on Apple, Spotify, Audible, or wherever you get your podcasts. You can always visit howwecanheal.com/podcast to share your thoughts and ideas as well. Before we wrap, I want to be clear that this podcast isn't offering any prescriptions. It's not advice or any kind of diagnosis. Your decisions are in your hands, and we encourage you to consult with any healthcare professionals you may need to support you through your unique path of healing. In addition, everyone's opinion on this show is their own, and opinions can change, right? Guests share their thoughts, not that of the host or sponsors. I'd also like to send just huge thanks to our guest today, to Kyle Arizbal of Prolific Sound Solutions, and to everyone who helps support this podcast directly and indirectly. Alex, thanks for taking care of the babe and the fur babies while I record. Lastly, I'd like to give a shout out to my big brother, Matt, who passed away in 2002. He wrote this music, and it makes my heart so happy to share it with you here.